The principles of hearing preservation, I think, really start from the days of Christoph von Ilberg in Frankfurt, and he basically quoted the principles of application of CIs is limited by the fact a usable hearing capacity in the majority of hearing patients is destroyed by insertion of an electrode array. And he's looking at the improving criteria of cochlear implants and trying to look at electrical acoustic stimulation was born those years ago. What I want to do is briefly just go over the background, what we know influences hearing, the grading system that's been published so that people who are writing papers on it can have at least have common terminology, and perhaps some thoughts about whether or not the surgical hand is better than the technology that could be emerging. We've known about the principles. Well, we in England had sort of gold, platinum and bronze type of levels, and that reflected the degree or profoundness of hearing loss. And in converse, in the opposite process, it is appropriate to say that the better your hearing, then the better the outcomes, because theoretically you've got more neuronal survival. But we found that if you actually implant people with too much hearing, there's a lot more to lose in the timbre and the clarity of hearing. So there is a sort of a happy medium. I think in England, 90 decibels at 2 and 4 is quite severe. We've seen people implanted at 70 decibels at those levels. I think that may be a bit too challenging, but a happy medium in between, and we would like to go to at least 80 or 85, and that wouldn't produce a huge expanse in the numbers of patients. The general principles I think we've all learnt over the last few days is an implant is built to very, very good specifications, but if you're implanting a 1-2-year-old child, then the logics are that there is a high probability that during the lifetime of that child they're going to need reimplantation surgery, and you need to be able to remove the electrode atraumatically and reinsert and try and maintain the same performance that we've had before. Influencing factors: the younger the body is, the better their resilience to repair. We know that duration of deafness, if you certainly from an adult's point of view, if you've been deafened within 10 years, the outcomes are usually very, very good. And from a child's point of view, we would, from a congenital point of view, we would be very hard pressed to really take anybody on after 4 years of age. Now, what sort of age group would you have? If somebody's been diagnosed at birth, has had hearing aids fitted, say within 6 months of age, and they come up to the CI unit, would you have an upper limit of implantation? And what associated criteria would you be looking for? Do you have departmental policy on age limit? So if you had a... Yeah. If you have a congenitally deaf child and they've been stimulated with a hearing aid and they're profoundly deaf, is there an upper age limit where you would not consider a cochlear implant? Upper limit. Yes.
Would they be too old?
Yep.
And you wouldn't say, you'd say that there was no benefit. How old?
Would you implant a 9-year-old who's congenitally deaf? Do you understand? Do you want to translate?
Yeah. Well, maybe I can just answer from what I see
Uh-huh.
clinics. Many clinics are trying to implant as early as possible. The guidelines, as Professor Cummins said, allow implantation to 12 down to 12 months
Yeah.
of age, but we still do see a number of children being implanted at much older ages than we'd typically see in UK
Yeah.
or North America.
So
So you would see 6-year-olds, 7-year-olds.
you monitor their outcomes. Perhaps I've got to talk later on the what's called the British Cochlear Implant Group, and it may be something that in your country, you probably do have collaborations between departments, but setting standards, which is also very useful for battling against bureaucracy of government if you have a unified voice. Going back to implantation, we know that steroids can help, and we've discussed surgical techniques. I think from an honesty point of view, there's probably very little difference in a round window technique versus a separate cochleostomy, but the angle of insertion is very, very important. Possibly the characteristics of the cochlear health is again important. So if you transgress the scala tympani and you get into the scala vestibuli, then you're going to have more problems. So there are modiolar hugging, there are mid-scalar electrodes and lateral wall. So the general principles, if they go in steadily, slowly, then stay in the tympani, then theoretically all should be able to offer a safe technique.
You use steroids in the middle ear catheter management?
Yeah, my process now is mastoid posterior tympanotomy, expose the round window membrane, put steroids. Sometimes I just put it in a syringe, sometimes put a gel foam, put it there, then go back, prepare the bed, the channel, so you've got 10 minutes or so at least of steroids in there. You need to just give a slightly higher dose of dexamethasone. There is a talk of a multi-centre global study on the role of steroids, but one of the arms is not to use steroids at induction, and there's a few countries that the anaesthetists, our anaesthetists wouldn't sign up to that because of post-operative nausea and just the way anaesthesia is given. They use steroids there. So again, our classical approach is transmastoid. We always use antibiotics because it's clean surgery, but it's not sterile surgery. You're putting a foreign body in. We use Dex at induction. Try and keep blood away, even to the extent of I'll put an adrenaline pledget around. Drilling, this is noise. Keeping bone dust away, because again, that is very reactive. You get inside. Cochleostomy, separate or round window. I do both. I do an extended round window sometimes. It all depends on positioning of the facial nerve. Can you get access, and can you get your trajectory of your electrode where you want it? It's easier said than done having a steady, slow insertion. I probably do grab hold of it, hold it, and then do it again. So it is maybe a little bit jerkier, but I think I want to hold the electrode as close to the cochleostomy to avoid any bending or anything like that. So you can actually guide the electrode better, and always seal the cochleostomy. Yep. And we've done a survey about steroids, and a huge variation, especially post-operatively. I've not gone out the way to give post-operative steroids because I've had some experiences where patients who have come in with sudden sensorineural hearing loss or facial palsies had big doses of steroids, which is what we tend to do, and they've had bad side effects. Anyway, the rest of the slides were just showing you about the angle of insertion, and then the final bits were robotics. There's various people, Rob Laverty and Vanderbilt. We've got some people at Ashton University in Birmingham looking at little burrs that drill onto eggs and sense the power that once it breaches the eggshell, it stops at the membrane. So doing your cochleostomy, having that haptic feedback of putting the burr in, right through to the extent of the Da Vinci systems, where you do prostate surgery, and whether or not we'll get into that, where you can do remote or targeted drilling, and with navigational systems certainly improving in quality for sinus surgery, whether or not the quality for skull base or lateral otological practices will improve, but a millimetre plus or minus a millimetre could mean the difference between a facial nerve, scala tympani or scala vestibuli. So I think the boundaries of navigational surgery, we tried the landmark system a number of years ago on an ossified cochlea, and it sort of helped a little bit with trajectory, but you're still feeling your way. You get that if you've done any ossified cochlea, you get this sort of white mushy stuff, and you can literally pick it out. But with the process of dealing with ossified, do scala tympani, no good. Try scala vestibuli, because we know that the cochlear duct, if you're going to get some bugs coming in, you're likely to get ossification in the scala tympani first. Try the scala vestibuli. If that's no good, go to the second turn by taking out stapes superstructure, take out the incus, and literally go in that front wall and aiming to the facial nerve, the process cochleariformis, and that will get you usually onto the front face. And there's Goran Bledberg and Thomas Lennox, and it really depends on which way round you go into the, well, what you will get into is in the scala vestibuli, and which way round you put the electrode. So you can use a compressed electrode or perhaps a 20mm electrode. And I think most people have gone off the roll of split electrodes, because our audiologists find them a right pain in the backside, very difficult, I should say, to program. So I don't know, does Nucleus produce the split 11 and 11 anymore? The split electrode, I mean,
Never used it in Japan, but
they probably still get it, but I think with roots in, and if you've still got huge ossification, but we've actually found that since we universally now do pneumococcal vaccination, we do hip vaccinations on children, I can't really remember the last true congenitally deafened child because of meningitis. It's in the last several years, you've seen fibrotic ears, but I haven't seen the true meningitic ears where you've been sweating to get a channel through. But I think there will be a subtle balance between pharmacokinetics, drug delivery, drug-eluting electrodes, and technology just to help us. And we've also got machines now that obviously measure the pressures that can probably clamp on and put the electrode in at a nice steady rate. There's one paper I reviewed some time ago, and they were looking at 15 minutes of insertion time.